locations to plot across a map the locations where the data have been observed, and then you might map things like prevalence.
Pulang dari rumah sakit. Dari dulu kayak Umi jadi.
Okay. Alternatively, maps might be area-based. So this is where you present the data aggregated by administrative or by some form of area, which typically would be an administrative area. So typically, for example, you might have disease surveillance data, and you don't know the exact household or the exact village that someone comes from, but you might know the district they come from, and that information will be aggregated up typically through a national reporting system, and then those data can be presented in an area-based way. Another term that's important for you to understand is the term spatial epidemiology. So you're all studying, or many of you have studied epidemiology, and you know that epidemiology is the science or the study of the distribution of diseases in populations. So spatial epidemiology is a sub-branch of epidemiology, and it's focusing on studying the geographical distribution of disease and its association with associated associated environmental, social, and other spatially varying risk factors. Okay, so it's an area of epidemiology. It uses many of the same techniques, but the thing that really makes it stand apart or differentiates it is the focus on location or geography. Okay. And then another term is spatial analysis. So spatial analysis, you know, a sort of formal definition is the use of statistical methods or other types of analytic method to study entities, which in our case would be disease patterns, using their geographical, topological, or geometric characteristics. Primarily, in the case of spatial epidemiology, we focus on the geographical characteristics, so the location of disease events and how that relates to factors in the environment. So typically in spatial epidemiology, we use spatial analysis to augment the visualization of disease patterns, also to help us quantify and explore disease clusters, to quantify social and environmental risk factors, and to predict the distribution of disease. So disease clusters are locations or areas where disease within that area is statistically higher than you would expect if disease risk was homogeneously distributed across the study area. In other words, disease risk is higher in a given location than the average risk across the entire study area. So that's how you define a cluster. And many of you will have heard of the term clustering with respect to things like cancer and other infectious diseases, and where people talk about this particular location having a large number of cases or a higher than expected number of cases. In a formal sense, what we do is we statistically evaluate that to determine whether or not disease risk is higher in that location than would normally be expected given the overall prevalence or incidence of disease. Yes, and as Evilione said, if you've got any questions, please write them down. I will also just briefly describe what I mean by spatial prediction. So spatial prediction is where you make a number of observations in a sample of locations across a study area, and that might be through a survey. And then you use that information in a model to estimate what the value of a parameter of interest is, which might be disease prevalence across the entire study area. So that's called spatial prediction. And then in spatial epidemiology, the output of that is typically called a risk map. And so that's a map of disease risk across a study area that uses a model to derive those estimates of risk. And I'm going to give you examples throughout the talk in terms of how we produce risk maps. Okay. Right. So here we have a simple spatial analysis framework, which is I'm going to use to structure the rest of my talk. And there are three, typically, or one way of conceptualizing spatial analysis is to consider that there are three different levels of spatial analysis. There's visualization, so that's the green box. So that's visually interpreting spatial patterns in disease data. There's exploration, which is doing a detailed exploration of the disease data to test hypotheses around things like disease clustering, etc. And there's modeling, where you build models to better understand disease processes and potentially to predict the distribution of disease. And all of that is underpinned by data, which includes attribute data. And in the case of spatial epidemiology, that's typically disease data, and feature data, which is typically information about physical environment. There are different outputs for each of these levels of spatial analysis. So maps might be an output of visualization, although maps are also outputs of exploration and modeling. A description of patterns is an output of exploration, and the formal testing of hypotheses is an output of modeling. Those are some examples. It's a bit of a simplistic framework, but it gives you an idea of the different levels of spatial analysis. So in the first part of the talk, I'm going to focus on visualization, which is really 90% of what people do. So this is something that you will typically do in your lives as epidemiologists. You'll look at maps and you'll visually interpret the data that you see. So visualization, as I say, it involves a visual evaluation of maps of disease data for the purpose of identifying spatial and/or spatiotemporal patterns in disease. Typically, it shows actual values, so raw data. They might be two-dimensional, three-dimensional, multi-dimensional representations of disease data. They might be points. Those points may be coloured to, or they may vary in size in order to describe variation of in a variable of interest. So it might be disease prevalence. You might have a map series where you visualize disease data over multiple time periods to visually observe changing spatial patterns in disease risk. And the purpose of it is really to generate hypotheses. So, for example, is there a pattern? Do the data appear to be clustered? Is there a trend from one area of the map to another area of the map in disease risk? What's the overall sort of spatial pattern of disease risk? Here we have two representations of exactly the same information. On the left, we have a map, and on the right, we have a table. In fact, the table only shows the first 50 or so, maybe 30 or so observations from a data set with 2,789 observations. So which of those two is easier to interpret? The map on the left or the table on the right? Well, if you're interested in knowing what the distribution of disease is, of course, the image on the left is much easier to interpret than the table on the right, because it demonstrates the spatial relatedness of the observations and allows the eye to identify visually underlying patterns in disease risk. Okay, so you can very clearly see on that map on the left that there are areas of the map where you've got more red and orange, and there are areas of the map where you've got more green. Okay, so that map on the left is called a Choropleth map. So Choropleth means that a variable of interest in an area-based map is represented on a colour scale. Okay, so you'll be very familiar with these kinds of maps, Choropleth maps, where a variable of interest, in this case it's the prevalence of an infectious disease in Tanzania, is represented on a colour scale. And just simply by visualising that map, by visual inspection of that map, you can see that there are areas of Tanzania where the prevalence is higher than other areas of Tanzania. And you can also identify potential clusters. So you can see that there's a potential cluster in the northwest in the area just south of Lake Victoria. There's a potential cluster in the south of the country near the border with Mozambique, and there may be some other smaller clusters, for example, in the western part of the country. So when we talk about Choropleth maps, there are three elements that are absolutely critical for appropriate representation of disease data. So I'm calling them the three C's. The first one is the color scheme. The second is how you categorize the data. And the third one are the cartographic requirements. So the color scheme here is a red-green color scheme. It's actually not a great color scheme to use for representing disease data because a significant proportion of the population are colorblind, and many people can't differentiate red and green. So a better color gradation might be blue to red, or it might be a monochromatic color scale where you might have different shades of a particular color. So, for example, red. So monochromatic means different shades of one color. Dichromatic means two colors. And then there are sort of multichromatic where you have multiple different colors in the color scale. But what you want is you want to have a color scale that has good contrast and enables you to identify clearly areas of the map that are of relevance to you. The second C is categorization, and I'm going to come to that later in the talk. But basically, what I mean by categorization is the way that you set the thresholds for the color scheme. So here we've got the thresholds are shown in the legend here in the map, can really influence the appearance of the map. The way that you create different classes in the color scale will have a big influence on how the map appears. And it will potentially also influence the interpretation of the map. And there are different color schemes. I'm going to show that in another slide. So just keep that in mind. And the third C are the cartographic requirements. Whenever you produce a map, a disease map, you need to make sure that you have some particular features on that map that help people understand the scale and the spatial relationships on the map. So one is that you need to have a north arrow or some representation of north, south, east, and west. Another is that you need to have a scale bar to give you an idea of distance. So here we've got a scale bar that goes from 0 to 400 kilometres to give you an idea of the size of the study area. The other element, of course, is the legend. You need to have the legend to be able to interpret the colour scale on the map. And then there are other cartographic features as well. So you need to have things like titles and etc. And also labelling. So those are the three key ingredients of a Choropleth map, or in fact of any kind of disease map. I'm going to talk about some examples. So some of you might have attended my talk. I think it was either last week or the week before. Many of the slides that I'm going to show are actually repetition of that talk, and I know that some of you have attended that talk, but for those of you who have, this will just be a bit of a refresher, but for everybody else, this will be new information. So when we talk about spatial data visualization in the context of public health, there are typically two different audiences for those disease maps. One is the general public. The other is health professionals that utilize maps in either developing policy or implementing public health programs. So I'm going to talk for a little while about two different examples. One focusing on spatial data visualization for the general public, and one on tools that have been developed for healthcare professionals to use. So really the example when it comes to data visualization for the general public, I'm going to talk about COVID-19. And COVID-19 has changed everything when it comes to the public consumption of health-related data. So, as you all know, it's the first major human pandemic, which I've defined as causing over 1 million deaths, since computers and the internet became available to the majority of the world's population. Okay, so it's a pandemic of the digital age. And health data are now more accessible to the general public than ever before. And the level of immersion in data and information is unprecedented in public health. You can go online and you can find literally 100 different data sources, different representations of COVID-related data instantaneously. Whenever you turn on the news or read a newspaper or go into your social media, you'll be consuming data related to COVID. And in many instances, that data will be presented to you in the form of maps. So, there are maps online looking at, the rate of vaccination or the number of people that are infected or the number of people who've died or the number of people in intensive care. And the challenge there is, of course, that firstly, that data needs to be presented to the general public in a way that is accurate and that is ethical. But also, you as consumers of that data need to know to understand it and need to know what the limitations of the data are. So that creates a whole lot of responsibility for the creators of the data and the consumers of the data. So many organisations are aiming to present data in a way that is engaging and of value for public consumption. And of course, spatial and temporal patterns of disease are really important for understanding and interpreting disease risk, hence the use of maps. Here we have the Johns Hopkins dashboard for coronavirus. This is probably the most influential, the most heavily utilised online data source for COVID-19. And you can see that right at the centre of this dashboard is a map. Here it's showing the number of cases of COVID-19 by different types of jurisdiction. So the resolution varies across the map. In some areas of the map in Africa, data is presented at national level. In other areas of the map,
recording in progress.
United States is presented at county level, which is actually the third level administration. It's a point map in the sense that each data point is represented using a point and it's scaled according to size. So the bigger the larger the number of cases. Now, of course, it's important to understand that these points are centroids. So these are the geographical centre of each of the jurisdictions. So for Algeria, we've got a very large jurisdiction here for the entire country. That point is not really representative of where most of the cases of coronavirus are located. But then when you go down to the United States at the county level information, those points will be, much better representation of where the population is located. Supplementary to the map is a whole lot of additional information.
Recording stopped.
So we have information on, so we have tabular information showing numbers of cases. We also have plots showing time series. So we have a plot of the number of daily cases, the number of daily deaths, and the total number of vaccine doses. This is a very typical sort of dashboard. It gives you multiple levels of information in multiple different formats. It enables you to drill down, to query the data. It also enables you to download data and then use that data for your own application, your own purposes. It might be to do research. It might be for some other purpose. It's an online dashboard, which means that it's available
recording in progress
through a website, and so you can access it by via the internet. Okay, so with COVID-19, what data variables are presented? So typically, so mainly it's epidemiological data on numbers of cases, numbers of deaths, including numbers of people recovered, etc. And this include counts and counts normalized by population in order to give you an estimate of incidence. There's also a whole lot of ancillary data that's been presented in relation to COVID. So there's things like health service utilisation, including things like hospitalisations, intensive care admissions, ventilator use, and testing coverage. And then there are more specialised systems that focus on particular areas of interest, which might be mapping population mobility, environmental suitability for social distancing, morgue capacity, etc. Some dashboards incorporate some modelled outputs. So, for example, risk predictions of different outbreak sizes. And of course, in the last 10 to 11 months, some of these dashboards are showing information on vaccination uptake and coverage. So what is an online dashboard? Well, it's a very effective means of public distribution of information, particularly if we're talking about mapping dashboards, then it's a very effective way of presenting spatial information. They're computerized systems with an underlying database and a web-based user interface. Okay, so there's a database underlying it, information's uploaded. Increasingly, that's done using electronic sort of data capture methods, but can also incorporate manual uploading of data. Then that data is georeferenced. So in the case of the Johns Hopkins dashboard, it's georeferenced according to an area or a jurisdiction, and then that data is linked to a map using a geographical information system approach. Online dashboards are highly interactive. They allow the user to select variables, to undertake queries, and to plot or map variables in different formats. Particularly, they allow people to drill down to particular jurisdictions or particular levels of aggregation. So you can pan into a particular area of the map. And as is the case with the Johns Hopkins dashboard, they often permit downloading of data by other users. Here we have another dashboard for COVID-19. This is the New York Times dashboard. And here we have county level information. And this time, rather than presenting it as a point, we're presenting area-based information. And this is an example of a Choropleth map. This is a static image. You can see at the bottom there's a little text box containing some information about a particular county, and you can sort of hover over the map and you can click on different counties and it will give you this particular information about that county. It gives you raw cases, gives you some information on incidence, and also gives you a little plot about 15-day trends. You can understand whether or not disease is increasing or decreasing in a given jurisdiction. With the New York Times dashboard, there are also different maps that you can access, and they are accessed via clicking at the top. So there are hotspots, risk levels, total numbers of cases, deaths, and then information on incidents. So another example of a dashboard. So what are the criteria for mapping, for disease mapping, for providing effective maps? Well, firstly, you can show crude numbers or you can show rates, which are indicative of risk. And I think the latter is more useful because the former is really influenced by the distribution of the underlying population. So you tend to have more cases where there are more people, but that doesn't really tell you about what your risk is in a given location. So that's why maps of prevalence or incidence, I think, are better. You need to decide what level of aggregation is appropriate and useful for decision making. So, typically you want to have this as high a resolution as possible without contravening people's privacy. So if your maps are too high resolution, you can potentially identify individuals or individual households or maybe communities, and that may not be appropriate. And so you need to have a level of aggregation that doesn't allow you to make that identification, but is also sufficiently high resolution so that you can fully understand the patterns of disease risk in order to inform decision making. The size and shape of geographical units influences visual interpretation. So particularly large geographical units are much, your eye is drawn to those. They tend to be, if we're thinking about, countries where you've got administrative areas, they tend to be geographically larger in, say, more rural and more sparsely populated areas. And the cities are obviously much smaller. And so if you have a map, for example, a Choropleth map, where you've got rural and urban areas, your eye may be drawn more to the rural areas because they're larger. And so that can be problematic for interpreting disease risk. And so there are different methods that can be used to overcome those problems. And you need to ensure that the classification scheme is appropriate for meaningful interpretation. So that's what I was talking about earlier when I said the categorization on the map. And this is the slide that I was referring to. So again, we've exactly the same data. So here's the map on the left that I showed earlier. This is a map where I've manually defined the classes or the categories. And I've done that according to some public health criteria that relate to particular interventions. So what I aimed to do there was to show areas of the map where prevalence was above a threshold at which the WHO recommends that you do community-wide interventions for that disease. That's why I chose those particular thresholds. If you can also define those thresholds purely statistically. And here we have 3 examples of how those thresholds have been defined, and you can see that those maps all look very different. So we have a map showing where we've used standard deviations to categorize the map. So basically you go 1 standard deviation from the mean and then 2 standard deviations from the mean. And then that defines the classes. And so what that typically does is it emphasizes the middle part of the distribution. And then you've got another type of statistical categorization called equal intervals, where you the maximum value, the minimum value, and then you divide that by the number of classes. So you work out the range, you divide that by the number of classes, and so each one of the categories has exactly the same range within it. So in other words, there are equal intervals, and you can see again that emphasizes different parts of the distribution. Typically, it emphasizes the central part of the distribution again. And then you've got the quantile approach. And the way that, what that means is that every category on the map has the same number of observations within it. Okay, so, and that kind of approach emphasizes typically the tails of the distribution. And so you can see that each of these maps looks very different. Potentially your interpretation of the map could vary. So you may think, for example, that there's a lot more disease if you look at the quantile map than if you look at the interval map. The reason why these maps look the way they do is because we have a very skewed distribution. And so with a very skewed distribution, the quantile map will emphasize one of the tails. In this case, it's the upper end of the tail. And an equal interval map with a very skewed distribution may emphasize sort of slightly closer to the lower end of the tail, to the lower tail. So you may look at those maps and, this is the same data, but you may interpret the maps completely differently. A little bit about data quality, which is critical to public trust and good decision making. It's important when you're presenting disease data to the general public that you're transparent around the sources of data and also the limitations of the data. This is an important point with respect to COVID because these pandemics are inherently very political things. We put in place travel restrictions, social distancing measures. Of course, there are public perceptions in terms of the competence of decision makers, etc. So I think it's naive to think that the pandemics aren't political, but it is really important to separate the political aspects of the pandemics from the scientific aspects. And the reason I raise this is because during the earlier stage of the pandemic, Donald Trump, for example, was putting pressure on public health authorities to minimise the figures. And of course, when that then creates a lack of trust in the data, and that's not helpful when it comes to the general public perception. And there are plenty of other examples around the world of political interference in the public dissemination of disease data, and it is problematic when it comes to trusting the public health authorities and the data that they use. There are a number of common sources of imperfect data, quality and consistency. The most critical one is underreporting due to the testing protocols that are used or the surveillance capacity of a nation. So typically, many cases don't get reported. If people are sick, they may not show symptoms, and they therefore may not seek health care, or they may be sick, but they may just go to a pharmacy and get Panadol, for example, and just stay at home without going to a doctor, and therefore their infection is not reported, right through to laboratories having limited testing capacity, incorrect diagnoses, etc. So there's a whole host of reasons why underreporting might occur. Also, it often happens that there are changes in diagnostic approaches or reporting definitions during a pandemic. So, for example, we may move from one type of diagnostic test to another, and there may be variations in sensitivity or specificity of that diagnostic test. And that has happened with respect to COVID. And definitely there have been changes in some instances with respect to reporting definitions or populations that are captured by the surveillance system. So, for example, in some countries like France and China, deaths that occurred either in the case of France in the community or in the case of China without a diagnosis of COVID were not reported as COVID deaths. And then at some point during the pandemic, those countries changed their reporting definition, and then that resulted in a significant change in the spatial and temporal distribution of the disease count. And so those things can also impact on the public perception of data quality. And then, of course, as is the case with everything, there's an element of error. It might be diagnostic errors, it might be errors in, it might be imperfect sensitivity and specificity of diagnostic tests, it might be errors in the application of laboratory protocols, etc. And all of these things impact on data quality. And also in systems where you've got manual uploading of data or manual transfer of data, there can be data errors as well. So that's the example of public, let me just check the time, of visualization for the public consumption. I'm now going to give some examples of visualization for the consumption of disease control personnel. I'm going to talk about a type of spatial data visualization tool called a spatial decision support system. So a bit like the online dashboard, these are electronic systems that link disease data with information on location and potentially information on ancillary variables that relate to the health service or the environment, in one system, and then they have outputs that include things like maps and tables and figures. So they are kind of similar to disease dashboards, but they're a decision support system in the sense that they're specifically designed to support decisions that need to be made with respect to disease control. So as for dashboards, they're based around a geographical information system that integrate a database management system, analytic models, geographical map display, and tabular reporting capabilities. And also some of them have functionality that enables the input of expert knowledge. The example I'm going to give you is one that we've developed for malaria. And the example I'm going to give you is one that was really tailored to the scenario of malaria elimination, where we needed real-time information at household level in order to aggressively target public health interventions to get on top of malaria transmission and eliminate the disease. Other spatial decision support systems are used more for, say, disease surveillance for endemic diseases, and they don't tend to be real time, and they don't tend to have that household level information. They tend to be operate more at an aggregate level, maybe at a district or a village level. So the spatial decision support system that we developed was for 2 countries in the Pacific called Solomon Islands and Vanuatu. These are 2 countries that were undertaking malaria elimination. And they had a number of provinces that they were trying to eliminate malaria from. And whilst they scaled up malaria control in the other provinces. There are a number of key operations that they needed to undertake in order to support elimination. So one was geographical reconnaissance, which is basically household mapping and enumeration of the population. There was scaling up of frontline interventions, including including bed nets and indoor residual spraying. And they also needed a high resolution surveillance and response system to identify cases when they emerged, do reactive case detection, and really stamp out transmission. So to accommodate those 3 operational requirements, we developed a spatial decision support system that had 3 different modules. So one was the geographical reconnaissance module, and that was really just a map of the households of the target communities. And so this is what it looked like in the spatial decision support system. You can see that we have a map of every household in these locations, and we have tables that link to the maps that contain information about each household, the number of people there, the number of structures that need spraying, et cetera, et cetera. The second element was, the second module was for to assist with the scaling up of bed net distribution and indoor residual spraying. And so our spatial decision support system was used to map target areas, delineate operation zones, which are areas where particular teams needed to focus on to deliver their intervention, and to generate detailed summary data. And practically speaking, to generate lists and maps. And this is what they look like. So here we have a member of the public health team whose role it is to do indoor residual spraying, and he produced a map from our spatial decision support system of all of the households within his zone of responsibility. And he carried a PDA with him, and he uploaded information as he went throughout the zone about which households he'd visited, which ones he'd sprayed. And that information was then captured in the spatial decision support system. And here we have an example of what the map looked like after one round of indoor residual spraying. So we've got the green households are households that have been covered, and the red households are the ones that have been missed. And then that map was then used to plan mopping up activities where they would go back and identify the red households and spray them. And you can see this was after the follow-up round of indoor residual spraying. And you can see that they got high coverage, but they did also miss a small number of structures. Okay, and then the third aspect of the spatial decision support system was for case detection, surveillance, and response. So the way that it works in these countries is that cases are reported to the provincial malaria office when they are identified in a rural health clinic. So if someone gets sick, they go to a rural health post. There's a nurse or a health officer there who'll use a rapid diagnostic test to identify whether or not they've got malaria. And then if that person's got malaria, they will radio through to the provincial malaria office and say that person X from household Y has been identified as having malaria. And that information is then mapped in real time using our geographical reconnaissance data. And then that is in the spatial decision support system. And then that information is used to identify zones of interest. So what you do with reactive case detection with malaria is you identify every household within I think it's a 1 kilometre radius of the index case, and you then screen people for fever in those households. And so the spatial decision support system was used to extract lists of households within those zones of interest. And here's another spatial decision support system that we built in Bhutan using a similar approach. So we've done some evaluation of the spatial decision support systems, and we've found that they provide an efficient and accurate framework to rapidly collect detailed information. They were found to be helpful in supporting decision making with respect to intervention planning, implementation, monitoring, and evaluation. And they were found to help identify transmission and support targeted response. And through qualitative research, they were found to have a high acceptability. However, when we returned to the Solomon Islands about 5 years after implementation, the use of our spatial decision support system had faded away. So there are obviously some issues. And the Solomon Islands is now using DHIS2, which is the District Health Information System version 2. So why have they done that? Well, we did some qualitative research to understand that. And the reason they've done that is because DHIS2 is a system that is endorsed by the World Health Organization. It's used by many other jurisdictions. So there's a community of practice. There's support available for it. With our bespoke system, it was vulnerable in the sense that only people within our team and within the country knew how to use it. So there was limited availability of support. And also our one was more resource intensive. So DHIS2 only collects aggregate data and doesn't involve household enumeration, which is fine for malaria control, but when we're talking about malaria elimination, that's problematic. So what our research has found is that there are particular challenges for bespoke systems, including the limited community of practice, the ability to mobilise trained personnel, the ability to further develop the system, the dependence on a small number of trained individuals. And we also found that household-based systems are difficult to maintain in resource-limited settings. Which in our case involved enumeration in pilot areas with external support. But what do you do when you want to scale up to new areas and where the country is in a position where they have to take responsibility financially for the maintenance and upkeep of the system? And what do you do when you go to larger populations, and what do you do when you go to mobile populations? How do you enumerate those populations? So that's some examples of some spatial visualization systems for use by healthcare professionals. I'm now going to move on and talk about data exploration. And before I do that, actually, I might just give people an opportunity to ask me any questions that they've got, because I'm a bit over halfway through the talk. I'm happy to give people a couple of minutes to ask some questions before we move on, if anyone would like to. Effie Leone, do you want to field some questions, or shall we move on?
We'll have a question and answer session in the end of the lecture.
Okay, we'll keep going then. All right, so one of the key endeavours when it comes to data exploration is to identify spatial dependence. Spatial dependence, I presume many of you will have heard of the term correlation. So correlation is the relationship, or how similar or different two things are from each other. And we do analyses of correlation. We look at how related two particular variables might be to each other, or two sets of observations. That's a really important concept in spatial epidemiology, particularly when it comes to how observations are spatially related to each other. So if something is spatially correlated, it means that observations that are close together in space are more similar than observations that are further apart. So if we think about disease risk, and we think about people in a cluster of villages, and we compare them to people from villages that are far away, if disease risk is more similar in that local cluster of villages than it is in villages that are further away, we call that spatial correlation. Okay, and many phenomena are spatially correlated, and most infectious disease processes are spatially correlated, and that's because there are two main reasons why spatial correlation occurs with infectious diseases. One is the fact that transmission of infectious diseases requires susceptible people, to be in close proximity, both in space and in time, with an infectious individual. Okay, so you need to be near someone physically and temporally in order to be infected by them through transmission. Okay, and so that naturally results in disease clusters, and which is manifest statistically as spatial correlation. The other reason why you get spatial correlation is because the drivers of disease risk, the risk factors, are themselves spatially heterogeneous. Okay, so if you think about malaria, you tend to get malaria in poorer areas. You tend to get malaria in more rural areas with the right sort of climatic conditions. So the right sort of temperature, the right humidity. So temperature, humidity, socioeconomic status, vegetation, all of these things are spatially heterogeneous. They all have a spatial pattern. And so there'll be some areas that are more inherently suitable for malaria or for any infectious disease than other areas. And that causes a spatially correlated pattern of disease risk. Okay? And both of those things can manifest in disease clustering. So with spatial data exploration, you're wanting to examine whether or not disease rates are more similar in locations that are closer together in space than they are to locations that are further away. As I mentioned, might occur because transmission is facilitated by close proximity. Might also be because risk factors are heterogeneously distributed. And then, of course, in traditional statistics, we have the assumption of independence. And if we have correlation, that's problematic. That violates the assumption of independence. And therefore, if we have correlation in our data set, we have to statistically amend for that correlation. So here I have, this is again more sort of visualization, data visualization, but it demonstrates the notion of disease clustering. So we have an epidemic of dengue in Guangdong province in the south of China. So the map is Guangdong province, and the red and yellow areas are counties of Guangdong province, or they might be townships. It's a sort of high resolution administrative area. And the red ones are the ones that are newly infected by dengue, and the yellow ones are the ones that are previously infected by dengue. So of course at the start, there's no yellow areas because there's nowhere that's been previously infected, but you've got a red area here in the sort of Pearl River Delta. And then you can see and visualize over time how the distribution of the epidemic changes. And you can sort of see that the epidemic spreads out from the Pearl River Delta to new parts of Guangdong, so the northeast and then the southwest. Okay, and then towards the end of the epidemic, you can see that there are no new areas, there are just previously infected areas. And you can see naturally that there are what appear to be clusters of dengue infection. They're around the Pearl River Delta, and then they're in the east part of the province and in the west part of the province. It's important to note, of course, that the population in Guangdong province is heterogeneously distributed. So you've got a large number of people living around the Pearl River Delta, in particular in Guangzhou, which is the capital city. And then you've got a large number of people living in the Taoshan area in the eastern part of it. But then the population is much sparser in areas outside of these main metropolitan centres. So a useful map then is to present an age-standardised cumulative incidence. So this is telling you what the disease risk is after accounting for the distribution of the population and standardising for age. And you can see that there are indeed some spatial clusters of disease risk in the area around Guangzhou, Shan, and other parts of Guangdong province. So this is just using simple visualization to identify disease clusters. But the next step of exploration is to actually try and quantify those clusters. Are they statistically significant clusters, or have they just arisen simply through chance, or as a result of some other cause? And so here we have an example of spatial cluster detection using the spatial scan statistic. So this is applied to data on Japanese encephalitis throughout China. So this is incidence of Japanese encephalitis by county over 4 different time periods. And what we've done is we've used a statistic called the spatial scan statistic to identify and quantify statistically clusters of disease risk. And so what the scan statistic does is it identifies a primary cluster indicated by the blue circle and secondary clusters indicated by the green circles. So what a cluster is what that means is that disease risk within the cluster is statistically higher than disease risk everywhere else. Or in statistical terms, you say that disease risk is higher than what would be expected if the underlying risk of disease was homogeneous, in other words, evenly spread across the study area. Okay, and so those are this is an exploration of the data to quantify the existence of disease clusters. These clusters are statistically validated, they haven't just occurred by random chance. There's a statistical basis to say that there is a significantly higher risk in these areas. We can extend this spatial cluster detection approach to detect spatial temporal clusters. So here we've used the spatial temporal scan statistic. And what we've identified is the primary cluster, but we've also characterised the time period over which that cluster has occurred. The primary cluster for this is scrub type, a different disease, is in the southeast of China, Guangdong province and the neighbouring province. And it's defined by a time period. So this is May 2012 to November 2012. Okay, and from these clusters, we can extract relative risks that tell us how more likely you are to be a disease case inside the cluster than outside the cluster, and then other attributes of the clusters as well, like number of cases, size, etc. There are other ways of determining the underlying spatial distribution or spatial patterns of disease. Here we have some data on influenza, swine flu from Brisbane, a city in Australia, aggregated by local government area. On the left, we have the raw incidence. On the right, we have a spatially smooth estimate. And what the spatially smooth estimate has done is it's taken out all the random variation that occurs. And it's enabled us to identify this underlying spatial structure in the disease data. So it's also taken out the effective number of covariates. And what we can see is that there is, in the underlying sort of spatial pattern, there is clearly a cluster in the southern part of Brisbane. And the central area of Brisbane is the eastern part of Brisbane is a lower risk area. Okay, there's a sort of statistically smoothing out the data to identify the underlying spatial structure. I'll go on, and here's an example from Indonesia, a study that we conducted in Sumatra, showing spatial clusters of dengue risk by neighbourhood in Medan City, and identifying a high-risk cluster in the southwest part of the city and low risk in the central part of the city. And we've used multiple different cluster detection techniques. So we've used spatial spatiotemporal scan statistic, which is the one in the middle. And on the right, we've also used a number of other techniques, including Anslin's local Moran's eye and the Geddes order statistic to find hotspots and cold spots. A hotspot is another word for a high-risk cluster. A cold spot is a term used to describe an area with lower than expected disease risk. And the good thing about these statistical analyses is that they're all consistent. They're showing similar patterns. They're showing different aspects of the data, but they're all consistent in the sense that showing a cold spot in the central business area of Medan City and the neighbouring neighbourhoods, and a high risk of dengue on the southwestern outskirts of Medan City. And then that becomes useful information for public health personnel to do, maybe to focus their surveillance on a particular area of the city, maybe to undertake public health interventions such as fogging or public health campaigns to clean up the neighbourhood, etc. Okay, so that's it for exploration and cluster detection. I'm now going to talk briefly about modelling. In particular, I'm going to talk about risk mapping, which is one of the, I guess, most typical spatial modelling approaches that we use in spatial epidemiology. So risk mapping, as I mentioned earlier, involves taking a sample of observations across a study area. So in this case, we've done a malaria survey. This is for Plasmodium falciparum malaria in Papua New Guinea. This is a national survey where they went to villages all across the country. They diagnosed people with malaria using microscopy. So they went into a village, they assembled people, they got a blood spot, they used microscopy, they determined that some people had malaria, some people didn't. And then that data is now represented in here on a point map where the scale of prevalence is shown on a size-based scale. So bigger dots, higher prevalence. What you do with risk mapping is you link that information in a geographical information system to environmental variables that you think may be associated with disease risk. So in this case, we've got precipitation, we've got elevation or altitude, we've got distance to the coastline, and in a geographical information system, we can link the value of each of these variables on the right with prevalence observed in our sample of locations. And from that, we build up a data set that we can use for modelling. And so we build a multivariable regression model that quantifies the association between all of these variables on the right and disease prevalence. And we then use the model to predict the prevalence of infection across the entire study area. We represent spatial prediction on a colour scale. Here I've used a red-blue colour scale. And that shows how risk of the outcome varies spatially across the study area. So we've got, red areas are high risk, blue areas are low risk. So that's a risk map that you can then use to plan public health interventions for malaria. Here's another study that we recently conducted in Ethiopia on tuberculosis. And in addition to a national survey, we also did a systematic review of the literature to identify published studies of TB prevalence, and we collated all of that information into a data set and built a model, and we spatially predicted the prevalence of tuberculosis, and we attempted also to demonstrate the uncertainty associated with our spatial predictions by plotting the standard deviation of the prediction at each location. So this is pretty much the same idea as the previous map. It extends the concept to incorporate the addition of supplementary information from the literature and demonstrates how we can also map the uncertainty associated with our spatial predictions. We can extend this further using Bayesian methods. So Bayesian statistics is an area of statistics that really has been transformative in our approaches to risk mapping and many other statistical applications. Bayesian statistics enables you to incorporate prior information with new information to come up with a posterior estimate of the variable of interest. But most importantly for risk mapping, implementation of Bayesian analysis using Monte Carlo simulation methods enables us to fully characterize the uncertainties associated with our spatial predictions. So the whole sort of concept is very similar. So you have surveys here. This is looking at schistosomiasis in East Africa, Uganda, Burundi, and Western Kenya and Northwest Tanzania. We've collated multiple surveys. We've extracted information on a host of environmental variables, and we've incorporated all of that information in a model. For those of you who've done multivariate statistics, you'll see that this is a logistic regression model with a particular term here, which is the statistical component. So here we have covariates. These are all of the environmental factors that we talked about in previous examples, and we have our outcome, which is indicated here, and then we have our modelled risk, which is the P. Okay, so we use that model to predict the outcome of interest, which is the spatial variation in disease risk. Okay, and here I'm showing it again. So we start with the disease data. This is for 2 parasitic diseases that urinary and intestinal schistosomiasis. We use the model to predict risk, and then what we can do from that is we can actually translate those spatial predictions into an intervention tool. Okay, so what I've done here is I've combined these 2 risk maps and created contours that relate to intervention thresholds as defined by World Health Organization policy. The World Health Organization says that we should be doing mass drug administration for these diseases, schistosomiasis, in all communities where prevalence of either infection is above 50%. And so that's the areas identified by the red contours. And we should be doing targeted mass drug administration, in areas where prevalence is between 10% and 50%. That's the areas between the blue and the red contours. And we should be not doing mass drug administration, but allowing people who are infected to get free access to healthcare in areas where prevalence is below 10%. Those are the grey areas on the map. So that shows you how we go from a survey to a spatial prediction map to an intervention strategy. And that for me is the kind of holy grail of spatial epidemiology. As I mentioned, with Bayesian methods, we can fully characterize the uncertainty in our spatial predictions. So the map on the left is our point estimate. It's the median predicted risk. This is the most plausible value of prevalence for each location in the map. But on the right, we're actually showing that effectively 95% confidence intervals. So we're showing that increased risk can be anywhere between the values in the top right and the bottom right. And that's really useful because it tells us that there are some areas of the map, particularly here, south of Lake Victoria, where we can be really confident disease risk is high. And those are areas where we have to intervene. And if we look at the map below that, we can see, particularly in the northwest and in the southwest part of the map, there are areas where we can be really confident the disease risk is low. And those are areas that we can confidently exclude from an intervention. And in many ways, that's actually the most important decision that you make in a public health program, is what are the areas that we can exclude? And that's a really tough decision because you're rationing your healthcare resources and excluding people from getting access to those resources. So you need a really strong evidence base in order to do that. And so this kind of mapping approach provides such an evidence base and really can help with improving the efficiency of public health interventions. Okay, and I'm going to talk a little bit, just to give a couple of examples of spatial analysis to understand disease drivers. Here's an example from one of your colleagues, Dr. Zita Husnina, which she conducted when she was in Australia working with us at the Australian National University, where she was interested in looking at the relationship between deforestation or forest cover and dengue risk. And so she chose to investigate that using a spatial modeling framework. So she had disease data. This is, you can see this is Kalimantan and Sumatra. She's got disease data there, and she's linked that to environmental variables. The one that was of particular interest was forest cover. Also some additional variables that are important environmental predictors of dengue risk, humidity and minimum temperature. Then there were two kind of outputs from this analysis that were of interest. One was what is the underlying spatial pattern of dengue risk? And you can see that Sumatra, the underlying pattern is relatively spatially random, but for Kalimantan, there's very clearly an underlying spatial pattern with a higher risk of dengue in the eastern part of the island. But the other output was quantifying the association between these variables of interest and dengue risk. And so she found, for example, that in Sumatra, dengue risk increased for a 1% increase in forest cover, which is a bit counterintuitive. But it also increased for a 1% increase in relative humidity. And in Kalimantan, dengue risk decreased with an increase in relative humidity and increased with an increase in temperature. Okay, so just giving you some ideas about the underlying spatial patterns or spatial drivers of disease risk. And this is another study that we've conducted recently in Papua New Guinea, looking at combining genomic data with data on the environment to predict the spatial distribution of different disease genotypes, to try and give us an idea as to whether or not there are different populations of the pathogen here, which is malaria, in different parts of the country. And the idea of that was to tell us about whether or not different areas of the country were isolated from each other or linked. And so here we have different genomic clusters. So this is one particular genotype, this is another genotype, and we used our spatial model to predict the relative predominance of each of these genotypes. So we can see that our map shows that this genotype dominates in the eastern islands of Papua New Guinea, whereas this other genotype dominates in the southeast peninsula of Papua New Guinea. And that tells you that there are relatively isolated populations of malaria parasite in different parts of the country. And that's useful information to tell us about the relative connectedness of human populations and their pathogens in different areas of the country. So that's all I'm going to say. Hopefully that gives you a broad overview of spatial epidemiology and disease mapping, right from the very practical through to the more scientific and the more theoretical. Terima kasih. I don't know if I said that right. Hopefully you understood what I meant. And I'm now open to questions.
Thank you very much, Professor Archie. It was a very comprehensive and insightful. For me personally, the spatial analysis framework I have been familiar with was mainly descriptive and limited to the exploration stage. So the modeling the use of MDG was a new thing for me. So yeah, thank you so much for Archie. It's really good to learn a new thing. So for all participants, should you have any question, you can write them in the chat box, or you can simply raise your hand to ask your question directly. But for now, we have several questions for you here, Professor Archie. Gus, would you help me to share the screen?
Yeah, I can see that there are a whole lot of questions there in the chat there. So have you taken them all down, Evie?
Okay. So the first question came from Dr. So different from when we use applications such as GIS, Geographical Maps, are maps that are manually created and colored based on selected data, such as those made during COVID-19 pandemic, enough to be used for research, and if it's not enough, what are the steps needed to make it more scientific? Thank you so much. For the question, Professor Archie, you can answer the question.
Thanks, Dr. Atuila. So, as I said at the beginning of the talk, 90% of the time, that's what people do, exactly what people do. They use geographical information systems to create maps. And for the purposes of visualization. And really that's where the majority of applications stop. And there's absolutely nothing wrong with that. But of course you need to understand the limitations. Firstly, you know, you can only get a visual interpretation of data can be sometimes misleading. So, you know, if you don't do the sort of statistical analysis to underpin it, you're not really sure whether or not the visual patterns that you're observing are real, or whether or not they have arisen due to other factors like the distribution of the population at risk, or random variation, or other problems that I didn't talk about, things like the modifiable aerial unit problem, where different levels of aggregation can result in very different appearing maps. There are also the issues that I mentioned around how you categorize maps and how you put them into different classes. All of these things can influence how maps appear visually. And then of course there are all the issues around data quality. So there's nothing wrong with just presenting raw data on a map and using that for visual interpretation purposes, so long as you're aware of all of the limitations that are associated with that. And that's really all I've got to say on that particular topic.
Okay. Thank you so much for the answer, Professor Archie. So actually, I have a second question for you. In this case, COVID-19 transmission mapping are mapped only for certain regions. In this case, it's for patients or districts. And the represents the transmission spread in that area. But considering that COVID-19 is pandemic impacting a large or more to be exact area, so should the transmission map be transformed to a larger area transmission mapping, for instance, of island or flat? Yeah.
Okay, so that totally depends on what data sets are available and what permissions there are to utilize data and present it. So, yeah, I mean, and it also depends on the decisions that you want to take as a result of having access to those maps. So for example, if you're a local public health official and you want to know where to distribute resources, maybe where to focus surveillance efforts, or you know where to increase sort of you know the number of ventilators or intensive care beds or whatever, you really only need information on your region. But if you're the national government and you need to know where to distribute resources across an entire country, then you need to have data across that entire country. So it depends on your level of responsibility, on the scope of your decision making, as to the area for which you need the data. Yeah, so there's that element, and then of course there's the element of accessibility. It might well be that data are only available for some areas, and then you have issues of incomplete data, and then you know there are different techniques you can use to infer what disease rates might be in an area where you don't have data, using things like interpolation methods. But you know, by and large, if you don't have data from those areas, it's difficult to know what's going on. So yeah, so it's a combination of access and accessibility and permissions to have data, and also what the purpose of that data is and the level of responsibility that you've got, whether it's local or national or some other level.
Okay, thank you very much for the answer, Professor Archie. So the third question came from Soyabako Onisa. The pandemic has had a huge impact on our health system, and as we know, we need to build better emergency preparedness system. It's complicated for us to know the factor data of particular diseases, especially if the disease is transmitted with animals as factor. For example, in the malaria case, what the data might be most useful, for example, for risk factors, etc. Thank you. Please, Professor Archie.
Thanks, Swabatul. Yeah, so there are many different types of infectious disease. Some of them are vector-borne, some of them are not. So malaria is an example of a vector-borne disease. It's transmitted by mosquito vectors. And with vector-borne diseases, you can do different types of monitoring. So you can monitor the disease itself in people. So you might do surveillance of people who are infected, but you also might monitor the vector. So the reason why you monitor the vector is because you want to understand, you may want to understand about risk of transmission, but you also might want to understand risk of re-emergence. So if you've got people and you've got the vector, but you don't have the parasite, you won't have disease. If you reintroduce the parasite into the population and you have the people and the vector, then you'll get disease. If you don't have the vector, you won't get disease. So you need to understand the dynamics of the vector to understand the risk of reintroduction. So there are multiple reasons why you might want to understand the distribution of the vector. You also talked about animal reservoirs. There are many different diseases that are, some that are vector-borne, some that are not, that have animal reservoirs. Japanese encephalitis is a good example. Scrub typhus is another. And again, you can do surveillance on the people, you can do surveillance on the vector, and you can also do surveillance on the animals. So you might trap rodents, for example, if you're interested in plague or if you're interested in hemorrhagic fever. You might have sentinel birds, for example, or sentinel pigs if you're interested in monitoring patterns of Japanese encephalitis. Now, of course, COVID is different. It's a directly transmitted virus. It's a respiratory virus that's directly transmitted between people. Originally, it was a zoonotic infection. So originally it occurred in bats, but then it ended up in the human population and became a directly transmitted respiratory virus. And so other than in the original location where the virus emerged from, there's probably not a lot of benefit in doing much monitoring of animal reservoirs, unless we think that the virus has now gotten into a new population of animal reservoirs who could provide a future risk for humans. But I don't think that there's a lot of examples, a lot of evidence for that. Some evidence that dogs and cats, for example, get infected with COVID, but no evidence that they're a major reservoir of infection for people. So it totally depends on the type of, on the disease. It totally depends on the epidemiology and the natural history and the life cycle of the disease as to whether or not you need to monitor vectors and reservoirs.
Okay, thank you very much for the answer, Professor Archie. We can proceed to the fourth question. From Hapriani Ilmada, dear Professor Archie, thank you for the explanation and the opportunity. I want to ask that how is the opinion how is the opinion of Professor Archie believe that there are still many people who do not understand how the data is obtained and the necessity of the published data is host and its linked to the environmental health? This question is quite similar with the Fadil Muhammad has asked regarding with the perception of the people and the perceived costs for people. Yeah. Thank you so much.
Okay. Thank you, Hapriani, for your question. Yeah, this is a key problem that we're facing in this pandemic, and it happens in all pandemics. So yeah, and how do we tackle that problem? So the way that we tackle the problem is that we ensure clear and consistent messaging from the public health authorities and from the government. We ensure that all of the evidence, all of the advice that's given is based on scientific evidence, and that government acknowledges the fact that their advice is based on public health, is based on evidence, scientific evidence. And we ensure transparency. So we're clear about the sources of uncertainty and error in disease in the data. Yeah, so that's what we do: clear, consistent messaging, transparency, and honesty. I think that's the way that we get maximize public trust. But we also understand, of course, that pandemics create anxiety, they create fear, and that's quite reasonable. Usually they're new pathogens. People don't have a lot of prior information about them. Sometimes we have new therapies or new vaccines that we need to roll out. And again, we need to be very clear with the public about the processes that are put in place to ensure the safety and efficacy of those vaccines, and that we're transparent about the process. And again, we need clear and consistent messaging from authorities. But we also need, as citizens, to take responsibility, to empower ourselves with knowledge, and not to be tempted by misinformation. So, the responsibilities goes both ways. So that's my view. Yeah, but we need to be compassionate and understanding as well, because of the fear and anxiety that people experience during major disease events like COVID.
Okay, thank you very much, Professor Archie. It was very insightful, and as I'm totally satisfied that your stage and honesty is important with the public trust. So the next question came from Rizky Sharwalberta. As you know, Cartographic Maps is now like an obligation, and what I want to ask is whether this will continue in the future, or will it return to how it used to be, which is not important for the maps or not.
Okay. Thanks for your question, Risky. And this is an interesting question because it demonstrates how information changes during pandemics. So when we started, there wasn't a lot of strong evidence that wearing masks was going to be effective. But then as we collected new information about the virus, it became very clear that wearing masks was going to be an effective public health measure to prevent transmission. And this is actually a feature of emerging infectious diseases, where we start out trying to apply knowledge from previous events from similar pathogens. But then as we accumulate new knowledge, sometimes the advice changes. And that can sometimes be difficult for the general public to understand. And that comes back to what I said earlier about the need to be transparent and honest about our level of uncertainty. So then it became clear that face masks were effective. And then as a result, we now have lots of countries around the world with mandates for face masks. I think the other thing is that public health behaviour is really hard to change. Behaviour is difficult to change. And but behaviour change is one of the most difficult things that you can try and do with any public health intervention. And it's, all of the hygiene measures that we're becoming very used to now were not the norm previously. You wouldn't normally sanitize your hand going into a meeting room. You wouldn't normally wear a mask. You wouldn't normally refrain from shaking hands with somebody. You wouldn't normally ensure that you maintain a certain amount of distance from other people. All of those things are behaviours that we've learned during the pandemic. What may happen, or what will definitely happen, is that many of those behaviours will drift away when the pandemic is put behind us, because memories are short, and we don't tend to learn very well from past experience, unfortunately, when it comes to public health. But what we hope is that some of those behaviours may stick for a period of time. Things like good hand hygiene, good hygiene around coughing, good behaviour around staying away from work and social and cultural gatherings when you're not feeling well. Those sorts of behaviours, hopefully they will stick for some time. But as I said, behaviour change is really difficult to achieve, and memories are short, and I'm sure that there will be an attenuation over time of some of these good behaviours that we've seen during the pandemic.
Okay, thank you very much, Professor Archie. So we can proceed to the next question. It came from Malfa Yoga. Dear Professor Archie, as explained before, spatial epidemiology, such as disease mapping, represents spatial or geographical pattern of disease on the map. So to conduct research in spatial epidemiology, is it possible to collaborate it with other related knowledge, like environmental health? Thank you.
Hi, Nafal. Thank you for your question, and the answer to that is yes. So, I mean, it's a bit sort of, it's almost a bit fake to say that spatial epidemiology is a separate branch. I mean, inherently, public health is a multidisciplinary activity. So it originated from the bringing together of a whole host of different things, like including sociology and anthropology, looking at things like the social determinants of health, medicine, biomedical science through the development of vaccines and other things, engineering through the development of hygiene and sanitation systems, statistics, obviously, epidemiology, etc. So public health and epidemiology is a multidisciplinary endeavour. Environmental health is just one aspect of public health that is also inherently multidisciplinary. And spatial epidemiology is a tool that can be used within, it's an area of scientific study that falls under the broad umbrella of public health or environmental health, whichever way you want to look at it. And I think for spatial epidemiology to be useful, you do need to take a multidisciplinary approach. So as a spatial epidemiologist, I work with microbiologists, I work with doctors and nurses, I work with environmental health experts, et cetera, et cetera. Yeah, so that would be my answer. So spatial epidemiology is very useful in environmental health. Absolutely.
Okay, thank you very much, Professor Ashish, for the answer. So the next question, one from Zenifa. Dear Professor Ashish, based on the explanation that has been given, conclude the data is not perfect. Therefore, how to optimize the data with the utility measure? Thank you.
Okay, this is a really big question. Thanks, Zenifa. The best thing to do is to have systems in place to ensure that the data are of good quality before collecting the data. Okay, so if we're thinking about a survey or a study, you want to make sure that you have really good protocols, really good well-designed questionnaires, that you do proper pre-testing, that you have well-designed databases, that you have well-trained personnel for data entry, that you have very clear definitions, that you have unambiguous questions for study participants, you do double entry, you utilize all of the electronic tools that are available to you to identify potential data errors, all of that. So there's that whole science of that whole area of data science and survey methodology that ensures that you get the best quality data. If we're sort of scaling that up to a sort of surveillance system at a national level, it all comes down to resourcing. It comes down to how well trained your personnel are, how well defined your surveillance tools are. So your notification forms and your electronic systems for data transfer. You need to invest in personnel, people who right from the sort of clinical coalface through to sort of data scientists and right through to public health personnel who analyse and interpret data and present it to policymakers. So it's a really big question, I suppose, is what I'm trying to get at, and it means having the entire system being functioning as well as it can. Now, you as a data analyst, when you get data, presented data, it lands on your computer, which is often the way. You need to have a good understanding of the data quality issues. So you need to know where the data comes from. You need to know how it was collected. You need to know what the survey tools were. You need to have a good data dictionary, and then you need to spend some time getting to know the data, really understanding what the variables are, and investigating the data for potential data quality issues. So, are there any values in the data set that don't make sense, or that don't correspond with the data dictionary? So, is there missing data? And if there is missing data, how do you
Recording stopped.
how do you adjust for that? I mean, and there are lots of different techniques that you can use to deal with missing data, but particularly multiple imputation being sort of the cutting edge approach. Yeah, so those are a couple of perspectives, and it's a big and complex topic.
Okay, thank you very much.
Recording in progress.
For the answer. So we can proceed to the next question. It came from Alvin Ubay. Thank you very much for your excellent lecture, Professor Archie. If we experience obstacles such as many cases that are not reported that affect the accuracy of our data, are there certain conditions that our data can still be trusted or displayed to the general public? Thank you. Please.
Thanks, Alvin. Well, I think no data is perfect. I think that's the starting point. I mean, if all data contains some errors, and what I would suggest is that you need to think ahead as to what the sources of error might be, and then you need to be transparent around when you communicate that data to the public, what the limitations of the data are. Of course, if the data are really bad, if they're really erroneous, and presenting that data to the general public may lead to people making decisions that are not in their interest because the data are wrong, or because the data may lead to some particular sort of public response that's not constructive or helpful or beneficial to their health, then you may choose not to present that data. And that is a judgment that you need to make as a public health expert. So it all comes down to judgment, but only present data if it's sufficiently accurate to give a true picture. Only present data if you're going to be transparent around the limitations of the data. Don't present data if it's going to be misleading. Don't present data if it's going to lead to behaviours that are not beneficial to people's health.
Okay, thank you very much for the answer, Professor Archie. So we proceed to the next question. It came from Ramit Pramureta. Dear Professor Archie, one of the challenges is that there is uncontrollable mobility while diseases come from the surrounding environment where it's very, very possible for the disease to spread widely. Then how to respond to this so that the data can be valid and the disease does not spread widely? Thank you.
Okay. Yeah, so population mobility is a really critical determinant of the spread of pathogens, and that's one of the reasons why one of the frontline public health responses during a pandemic is to stop people moving. So putting in place travel restrictions. As an example, in my country, we closed our borders. We didn't let anyone travel into the country. And then within our country, we have states in the same way that Indonesia has states. Our state governments have closed our internal borders and stopped people from travelling between different jurisdictions. On top of that, when we've had outbreaks in different cities, we've had lockdowns where people haven't been able to leave their house. So all of these are approaches that are put in place to minimise population mobility and the spread of the disease. Now, of course, these are very disruptive and very expensive. They have a big impact on the economy. They have a big impact on social cohesion and morale and mental health and all of these things. And you really only do it if the benefits outweigh the public health costs or consequences of not doing it. But it is one of the key strategies that we have, one of the most effective strategies we have for preventing the spread of pandemics. I think you also talked about, I'm trying to remember, you talked a little bit about, was it spread the environmental aspects? And I think another thing to consider is that COVID originated most likely in southern China as a spillover event from bats going into probably an intermediate species and then into the human population. But the question is, I mean, and we're seeing these spillover events more and more. And the reason for that is because there are more and more interactions, either direct or indirect, between humans and wildlife as a result of fragmentation of natural habitats through things like, logging and mining and, building of roads through natural environments and population growth and, population pressure. And so therefore people move, infringing more on natural environments. And all of these things, of course, are going to lead to more and more of these spillover events and, more frequent pandemics. So it's just the reality, I think, of the 21st century. And I think it is important for public health advocates, I think also for planning officials and governments to think about this and think about how they may mitigate the risk.
Thank you very much for the answer, Professor Archie. So, yeah, we have 3 questions left.
Okay.
And this is from Isa Sabina. Dear Professor Archie, if there is a condition of a COVID patient who was initially under surveillance but is no longer supervised because he is asymptomatic, how can this condition affect the data? Thank you.
Okay, I can talk broadly about the issue of asymptomatic infections. So basically, if someone's asymptomatic and they're not identified through contact tracing or through testing programs, then they're not going to be identified in the surveillance system, and they'll be undetected, and they'll contribute to the amount of underreporting. And for many diseases, including COVID, asymptomatically infected people can transmit the virus onto other people. Those people may become symptomatic, they may not. So asymptomatic people are actually probably the most important people in a pandemic because they're the silent carriers of the disease, and you need to have a system in place to identify them, because if you don't, then the disease continues to be transmitted in the general population, and then can crop up as symptomatic infections in other places. So we need to have a good system for identifying asymptomatic carriers, and as I mentioned, the 2 key ones are testing campaigns, testing programs, and contact tracing.
Okay, thank you very much, Professor Archie, for the answer. So, okay, the next question is from Al-Habsi Kusumadineta. For Professor Archie, I have permission to ask based on the data that has been able to show that the death rate due to COVID-19 in the last few months has been high. My question is, if the death rate is declining, can a detailed system analysis be made so that the general public can easily find the decline? Thank you.
Thanks, Al-Habsi. Well, death data are one of the types of data that have been publicly distributed during the pandemic. I mean, ultimately, that's the most important variable, isn't it? I mean, the number of people infected is important. The number of people hospitalized is very important, because that is information that's required in order to scale the health system response. But the number of people dying ultimately is the one that I think speaks to the major impact of the pandemic on disease burden. Although, of course, we're now hearing a lot about long COVID, which may also be another major public health burden in the future. So I think it's really important for the general public to know about mortality rates. I think that's going to be the key thing that actually drives public health behaviour. I think people are most concerned about themselves or their loved ones dying. And so if you can be transparent and present death data, then you're going to be more likely to drive the kinds of public health behaviours that you want. But of course, the flip side of that is that it can create anxiety and fear. And so there needs to be strong, I guess, public trust in not only the data, but also in the capability of the public health system to respond and protect them from disease. So yeah, I think that, and of course, and I, my presentation gave you many examples of the types of analyses that you can do in order to present death data. So hopefully you'll take something from the presentation.
Okay, thank you very much for the answer, Professor Archie.
You're welcome.
The last question came from Mutia Jasmine. Dear Professor Archie, thank you for the amazing lecture. May I ask you which kind of disease is more effective and easier for the public to understand for COVID-19 cases, since each kind of map has pros and cons? Thank you very much.
Thanks, Mutia. Well, you'll see like on the dashboards that there are many different types of maps, and actually quite often it's a good idea to present different maps so that the people can get a broader understanding of the current state of play with respect to the pandemic. But of course, the standard one, and the one that most people are most familiar with, is the Choropleth Map, which shows disease rates within jurisdictions. And they're really effective means of visually displaying disease data because they represent disease rates on color scales, and people are just very familiar with that sort of visualization approach. So, but there are lots of different ones. There are more sort of innovative approaches, things called Cartograms, for example, that change the shape of change the size of each jurisdiction relative to the number of people in it, for example, so that it highlights highlights sort of more densely populated areas of the map. There are lots of innovations, but really I think the standard one, the one that people are most familiar with, and would be Choropleth Maps.
Okay, thank you very much, Professor Archie, for the answer. So, yeah, that was our last question. I can see all the participants are very excited. There are lots of questions, and thank you so much, Professor Archie, for such giving us a satisfying answer, and it's very insightful and comprehensive for us. Yeah, once again, thank you so much for the active participation for all participants, and thank you very much, Professor Archie, for our session today. I believe that we need more sessions about the disease mapping to control the outbreaks with you because it's very insightful. Yeah, and yeah, as an epidemiologist and a public health practitioner, it's very important for us. So, okay, before we close our session, we need to take photos together, and it will be guided by Bagus. Bagus, are you here with us?
Okay. Okay, now we have 6 slides over here, and I'm going to take some photos. To all participants who are able to turn on your camera, please turn your camera on. Oke, bagi teman-teman yang mungkin bisa untuk menyalakan kamera, bisa dinyalakan ya kameranya. Okay, I will count 1, 2, 3. Okay, next slide. 1, 2, 3. Okay, next slide. 1, 2, 3. Okay, that's it because the rest of the slides, they are turned off with the camera. Thank you.
Okay, thank you very much, Bagus, for the documentation. Okay, can I give it back to Dr. Etta? Dr. Etta, are you still with us?
Yeah, thank you. Thank you very much, Eveliani, for guiding this lecture, and thank you. I would like to, on behalf of Faculty of Public Health, Universitas Airlangga, I would like to thank to Prof. Archie Clements for your very insightful lecture today, and I believe that this lecture is very interesting and beneficial for the students, and yeah, maybe one of them someday will study directly with you in Australian University, Australian National University, maybe Avilioni, maybe.
Oh, that would
You
be
want to
wonderful.
study there, yeah.
I'm not at the Australian National University anymore, but yes, that would be wherever I am. That would be wonderful. Yeah.
Oh yeah, yeah. So good. So I also thanks to Zida Husnina who make this lecture happen. And
Yeah. Thank you, Zeta.
Bagus, yeah, and Bagus for help assist us for everything, and all the students. I would like to thanks to you for your attendance, and hopefully we will meet again in the next sessions. And I believe it will be as interesting as this session, I think. Yeah, that's all. I want to I really want to express. So thank you. Yeah.
Thank you, everyone. It's lovely to meet you all. See you next time. Bye-bye.
Bye. Have a nice day.
Bye.
Recording stopped.